So let's move on to generalized anxiety disorder, which has a variety of subtypes, panic attacks, OCDs, PTSD, and social anxiety. And so would you comment on that, what advanced nutrient therapy would do for these folks?
Okay, we have just recently now put together and beginning to publish the phenotypes of anxiety. And most doctors, including the doctors we work with, don't have the insight you have of the different types of anxiety. And there are three major forms of anxiety. And I think you already know what they are. For example, there are the overmethylated people who have excessive activity at norepinephrine primarily. And that means anxiety. And especially if they don't have enough GABA activity to balance that. So that's one of the major phenotypes. And that was the first one we knew about. Then the second phenotype, completely different form of anxiety, are people who have a copper overload. They simply have a metal metabolism problem in which they don't have the ability to regulate copper. Especially happens at hormonal events in females like puberty, childbirth, later in life, and menopause. And what happens is during those periods, their copper escalates. And now after the baby's born, the copper level is supposed to go right back to normal. It more than doubles during that period. And high copper levels cause enormous increases in norepinephrine, which is an anxiety neurotransmitter, basically, and causes hyperactivity of norepinephrine firing. So that's one of the key forms of anxiety. And that's my favorite form because all we have to do is fix their copper and they become normal. I know you've experienced that. And these people can suffer the rest of their lives if they don't know that. All it takes is the blood test and you see their serum copper is sky high, and you know how to correct that. It takes a while. You have to be careful and cautious. But within 2 to 3 months, most of these people who've suffered many times for years are completely okay. So that's the second type. And the third type, you've already mentioned it, are the OCD type people that have the internal great tension and really very high anxiety. And OCD is an anxiety condition. And these people have this because of undermethylation. They're undermethylated. And this has a real impact on not the kind of anxiety where you see somebody walking down the street who you're a friend and you can see how anxious they are. Many of these people have great anxiety behind a calm exterior. You don't see it in their face or their actions. It's a completely different form of anxiety, but that's the third type of anxiety. We now can readily diagnose it, identify which form of anxiety a person has if they have generalized anxiety, and we have a roadmap how to fix it. And we also can suggest medications that might help if you want to employ them also.
I also see a lot of people suffer from anxiety who has also pyrrole disorder. Can you comment on that, about why it's not included in the phenotype you were talking about?
That's a very smart question, by the way, and I've thought about that. And the pyrrole disorder usually involves very low levels of zinc. And so these people generally have a copper-zinc imbalance. So the fact that they're so low, unusually low in zinc regulates copper. And so the pyrrole people, to help with their anxiety, is by correcting that. Really, for anxiety, we're normalizing their copper level. And that's why we put that together. But it's a subset of that one phenotype. It's a subset of a copper phenotype. So you're a very good, smart question. But that's why.
Okay, so it's a subtype of overload of copper, relatively speaking.
Yeah, the copper is regulated in humans by a gene called metallothionein. There are 4 metallothionein genes, and they have the responsibility for normalizing copper because it's so important for neurotransmission. For most people, it works beautifully. And I tell people, even if they were chewing on copper bars all day, if that metallothionein system was working, their levels would be pretty normal. But a lot of people don't have that ability. And there are SNP, single nucleotide polymorphisms in DNA for metallothionein. And now we know which ones they are, and they can really weaken that ability. And it turns out that the way the body normally adjusts if you don't have enough metallothionein expression is zinc. There is a metal regulation element in DNA adjacent to metallothionein, and it involves zinc. Zinc is what causes that to function and say, hey, we need more metallothionein, or copper is too high. It's really zinc that does that. And so we now understand exactly why. But if a person has pyrrole disorder, it means that they have a double deficiency, zinc and B6. And the zinc part is responsible for the anxiety.
Great, thank you so much. In my clinical practice, one of the most challenging type of patients has a tendency to be bipolar, quote unquote, or bipolar depression, or type 1 or type 2. And even though we discovered them having pyrrole disorder, they also have a undermethylation as well. And for some reason, just trying to correct these two conditions did not seem to have the same impact on them as we treat people, say, have just major depression or other diagnoses like OCD. And so it looked like bipolar has something more than what we know about. Can you comment on that?
First, I'd like to say, I think you've been asking me the best questions I may have ever received in an interview. Bipolar disease is different. It is not like depression. It's not like schizophrenia. It's an entity unto itself. It's unique and it's different. For example, it has the strongest genetic tendency of all disorders. It's far more, if your mother and father have bipolar disorder, you're about 80% likely that a child will have bipolar disorder. Whereas with schizophrenia, it's only about 30%. And so there's a stronger genetic tendency. But the unique thing about bipolar disorder is that, first of all, the median average age for onset is age 25. So it's a late onset disorder. And yes, some people have symptoms and things going wrong before the onset. But many patients, I've had hundreds of them. I've had a total of 1,600 bipolar patients that I've evaluated, and I have their chemistries. I've had many cases of people that were doing just spectacularly well in life, and then in a very short period, they developed very surprising anxiety and mania, and then were diagnosed with bipolar, and they had this problem the rest of their life. And they would cycle between mania, and the mania tended to always increase and worsen, and then suddenly shift into a depressive phase. Now, sometimes there would be a period in between, for some people, a period of being okay between the two cycles. But for some people, it's very quick. And as you probably know, bipolars can shift from mania to depression, a completely different condition. If you don't get effective treatment, they might cycle the rest of their lives. It's the most deadly disease of all mental diseases. It has the by far the highest suicide rate compared to schizophrenia, depression, anything else. It's far and away the most deadly. And one of the problems is that the depression in bipolar is different from the depression in other conditions, like regular depression or even the depressions in schizophrenia. So something's different. Now, about 7 years ago, I was not happy with our ability to help bipolar patients. I understand you're seeing the same thing. We usually can. We found that many of them do have oxidative overload or metal metabolism problems or methylation disorders or pyrrole disorders. And they usually report improvements, but they usually don't report that they're completely okay, that it helps a bit, but not nearly enough. And because it was so disappointing, I decided to spend 6 months just diving into new neuroscience research, trying to get insights or some understanding of why we don't understand bipolar enough. I mean, even though bipolar has been known for more than 100 years, about 125 years, we still don't know what the cause is. We don't know what's the mechanism in the brain for cycling between mania and depression. There was nothing I could find that could explain that. And what we had was just generally trial and error use of medications, usually starting with lithium that was discovered accidentally by a Dr. Cade in Australia back in the 1950s. It was a complete accident where he was doing experiments where he was injecting urine from bipolar patients into guinea pigs that were family pets in his backyard. And he was trying to understand from his animal study, it was very crude. His problem was they didn't tolerate the high uric acid levels. So he decided to put some lithium in to enable him to get higher uric acid levels just by an accident. And he found that the lithium made his guinea pigs calmer. He started trying it on people. It made bipolar patients a lot calmer, and it just started to spread. The problem was that some of the patients, human patients, died from liver or kidney failure, and it got banned for a while. But eventually they found that there are safe ways to use lithium. And so even that medication, which is probably the most effective drug medication for bipolar, was not because they understood bipolar disorder, but because it was just an accident. Okay, so I've now spent 7 years studying neuroscience, and I believe I found the answer. I think I have found right in all that new research. There are 250,000 neuroscientists in the world. And every month, there are more than 1,000 journal articles with new information. There's an explosion of understanding of how neurons and how the brain works. And very little of that has made it into clinical practice. And I think I stumbled on, I don't want to say I stumbled on it, but I believe, what it truly is. And I'm writing a book on it. I've been writing the book for a few years, and I'm very close to doing this. And a couple of years ago, I went to the annual meeting of the American Psychiatric Association, and I presented what I believe is the cause of bipolar disorder. And I'm quite sure this is correct. And what it is unique among mental illnesses. It is the inability for our brain neurons, our 80 billion brain neurons, to achieve the really high voltages or potentials that our neurons achieve. We have 80 billion neurons, but each voltage of these tiny little microscopic pieces of protoplasm, if you took 20 of them and somehow could link them together in series, you'd have enough voltage for a flashlight battery. There's they have amazingly high voltages. Well, the voltages, turns out, are enabled by about 400 genes. And most of these genes are ion channel genes embedded in the neurons that are responsible and enable these very high voltages. And what we discovered is that what happens, the reason a person may develop bipolar disorder, is that there are enough SNP mutations or a loss of DNA integrity that some of these 400 genes that collaborate to allow this are damaged to the point they cannot achieve the same proper high voltage. And that means mania. And then we discovered that if this happens, if you do a mass balance on these neurons, you find out that the mania will continually improve, worsen and worsen and worsen, to the point where it can overwhelm parts of the brain to function. And some of the parts of the brain function very well because their history is full of people with severe bipolar disorder who achieved a lot, like Winston Churchill and Vincent van Gogh and Isaac Newton and a lot of celebrities today, movie stars and singers, have achieved a lot. So we know that part of their brain is functioning well, but part of it doesn't. And it appears that what it does is it disables the RAF nuclei of the brain, and that's what creates and distributes serotonin. So the depression in bipolar disorder, and by the way, people who are bipolar, and I'm sure you have many of them, if they're undermethylated, for example, and you give them SAMI or methionine that normally would improve this, you get very marginal limited impact. The reason is our treatments until now have been trying to improve reuptake. They don't have a reuptake problem. They have a serotonin poverty, and they need a different treatment approach. So I hope to get this book out, and by the end of the year, it's something I try. I'm still working on about two hours every day. But I think it would be wonderful for the world to understand why it's different. We also understand why these people tend to have high pyro levels. It's unusual for any group like bipolar patients. It's about 95% of them at least have really high oxidative stress. Well, it's oxidative assault on DNA that damages their DNA integrity and results in many of these 400 genes prevents them from functioning properly. And that's why it's probably the leading cause for loss of genetic function. And so, of course, they still have that problem and it's still bothering them, but it's not that key to the condition itself. I think that's something that it's hard to fight an enemy if you don't know what it is. And I think my contribution is I think we now have discovered and are clearly showing what it is. And hopefully the neuroscientists of the world and even people who are developing better drugs or better therapies can use this information and then not just trial and error, try and develop new medications, but actually go directly to what is causing it in the change in brain function.
I also noticed in the bipolar patients, they have a tendency to have a higher uric acid blood level. Is that the case you have observed?
We've seen a bit of that. One thing we've learned, I'm not sure if you're familiar with this because it's very recent. The research we're doing shows that most developed countries, that the incidence of undermethylation in human beings is dramatically increasing over the last 40 years. And there's been an explosion of cases of undermethylated conditions like OCD. There's an explosion of the incidence of OCD. There's an explosion in gambling disorders, which are associated with undermethylation. There's an explosion in drug abuse, heroin, cocaine, et cetera, undermethylation. There's an explosion in autism, which is a virtually always an undermethylated disorder. And I think there are now very clear, but not very well publicized neuroscience studies that explain why. It explains why we have now more than doubled the folate level in human beings just by giving everybody folate so women won't have spinal bifida if they get pregnant. We're learning a bit about that. And I think what this is going to lead to, I really believe from what I've learned about bipolar disorder is that I think that this is a very complex condition. It involves many misbehaving genes, many misbehaving aspects of brain function and of human function, and very complex and very difficult to treat and correct. But it seems like it is going to be really relatively easy to prevent. I believe we'll be able to take an inborn baby, identify people who are prone to bipolar disorder, and be able to treat them so they will not receive it. I think that's going to be the future of bipolar disorder.
How does your discovery of cause of bipolar disorder and translate into any new blood work or urine test or any new nutrient therapy in addition to what we are doing now?
I think we should do what we've already doing. That is the pyrrole disorder and the metal metabolism and all of that. I think those are what we call concomitant conditions. There are things that can make treatment worse and make the patient worse, but I think they don't directly point at bipolar disorder. I think what's going to happen is that our DNA has 3 billion base pairs. It's really tied into the loss of integrity of key parts of the DNA, parts of the 21,000 genes, and some of them lose capability, which is why we age. It's why we develop heart disease. That's why we develop cancer and why we develop bipolar and schizophrenia and all. And I think that the key is, as time goes on, we're learning more and more about each gene. We now know roughly between 90 and 95% of all genes. We know what they do and why they're important. Most of that's from animal experiments. What I think is going to happen, for example, we know which 40 genes regulate potassium ions. We know which genes are associated with glutathione ability in the body. We're learning that, but we've only begun to learn it. And what's going to happen is there are going to be genetic tests that don't exist today. And we eventually will be able to catalog all 21,000 genes and the 80,000 proteins that they can produce. And we can test a newborn baby and identify who has weaknesses and strengths in what particular areas. We'll be able to identify women prone to, say, breast cancer or other cancers. This is coming. It's going to happen, and it's inevitable, and it's going to be wonderful. I really believe that it's going to be primarily that. Then, of course, you're going to need treatments to cope with these problems. So there will be a large number, I think, of new lab tests. I'm hoping what my book will do is get all the scientists and people to study this and develop creative ways to cope with the problem that we've now defined.
You mentioned the words serotonin poverty. And what does that mean, and how that affects we treat serotonin deficiency that we're doing now?
Okay, most of us, because of genetics, who are healthy and typical, when we're born, we don't have a lifetime supply of serotonin. It's created every day. All day, every day, our body is making more serotonin. Okay, we now understanding how that occurs. But some people are low in serotonin activity because of not just the amount of serotonin, but even more so the function of the genes that enable serotonin activity, the firing of serotonin neurons into the synapse. So what this means is that we have to have serotonin, or else we're going to have a problem. And in bipolar disorder, I believe it's serotonin poverty, because we've disabled the RAPE nuclei. I'm not sure I'm pronouncing that right. RAPHE nuclei, which are it's a part of the brain, mostly in the base of the brain, but the neurons go throughout the brain, and that's where the serotonin comes from. That's where it's produced. By the way, you don't have that in your body. The serotonin in your body is very important, but it's completely different. The synthesis of it is completely different from the brain. The brain, it all comes in the RAPE nuclei, and we know the steps. But if that's shut down, as I believe it is in most bipolar cases, then you simply don't have enough serotonin, and it can't be fixed by reuptake. It might be adjusted a bit. We need to somehow cope with that with treatment, and I think people will be able to develop that now. Now they realize that that's really the problem.
In Chinese medicine, which basically focuses on the energetic imbalance, describe bipolar as excessive yin as a depression and excessive yang as mania. So, but still went through this cycle. And from energetic perspective, do you see the parallel between biochemical imbalance in bipolar versus energetic or electronic? Or is it basically the electronic changes that affects the serotonin functionality?
Well, I think as usual, the Chinese tend to have more insight in a lot of these things because they've been working for so many thousands of years. Yes, energetics are everything. And really, if you look at bipolar disorder, diminished voltages makes the neurons more energetic, and they fire more rapid. You get hyperactive neurons, and that affects primarily, I think, norepinephrine and adrenaline. Those are the energy aspects, primary energy aspects of the brain, of neurotransmitters. And yes, it's energetics. And what happens is that when bipolar strikes, when the neuron voltages are not large enough, the voltages are too close to the threshold for firing. And so you get hyperactivity. The problem is that if you have a chronic mania, which is energetics really, it gets worse and worse and worse until you get to the point where you no longer can even form a potential enough to fire, and they just sort of shut down. There are scientific articles that show how that can happen to parts of the brain. Wow. And I think that's what happens in bipolar, but it's all because of this loss of the ability to form these remarkably high voltages for these tiny little microscopic neurons. Well, I might be wrong. I have to say that I'm not 100% sure, but I say I might be wrong, but I doubt it. Let's put it that way. It's not Bible yet, if you want to use that term.